So, Dr. Gary Cuddeback is the Dean of the School of Social Work, and he has been involved in dozens of projects focused on individuals with serious mental illness, especially individuals who are involved with the criminal justice system. And he has published papers about physical health needs of justice involved individuals with serious mental illness, the prevalence of individuals with mental
Uh,
illnesses in prison,
don't
the
read all.
role of med. Okay, he doesn't want me to read it.
Yeah,
Well, I was reading it,
yeah.
but
Thank you.
can I just say that's why I'm glad he's our dean? All right. Thanks, Gary.
You bet. Yeah, there's nobody cares about papers I've written. Um, right. I'm so delighted. Sorry for the logistical issues. I'm so pleased to see everybody here. This is the second in our series. So for those of you who may have seen me the first time, there's a little bit of overlap because in talking with Cassie, there was a request to talk some more about my own research. So you'll see some of that, but it's all going to tie together. I'm very informal, so if you have questions, um, let's do it as we go, so we can make it as interactive as possible, um, and would be happy to do that. So I hope we have a spirited and engaged group tonight. So first in our lecture series, Introduction to Serious Mental Illness. Um, so delighted that everybody is here. So here's some context that what we're going to do is walk through some of the history and treatment of individuals living with severe mental illness. So before we do that, though, I want to set this context for you that many of you may know if you work with this population. And then we're going to come back to this very same slide later, and we'll think through, are things better or worse? What are still the issues? Um, so as you know, folks living with severe and persistent mental illness have a lot of complex needs. So there's lots of social isolation and stigma, lots of unemployment, lots of substance use, lots of chronic physical health problems that folks often don't get treatment for. Um, there's often a lot of homelessness and transitory, movement, particularly in our large urban areas, right? So think about this configuration of problems and folks living with these issues as we talk some about the history. All right, so setting that, let's do a little bit of definitional stuff. Cassie, did all of the graphics show up on that one? Okay, so this definition of severe and persistent mental illness really comes from the 1980s when there was a movement after deinstitutionalization to try to, which we'll talk about, to try to define and count individuals with mental illness for mental health policy and planning and services. So really what it comes down to is the 3 Ds. So diagnosis, disability, and duration. So when we talk about severe and persistent mental illness, it's really, this is the way it's defined. So diagnosis, and we'll talk about a little bit. I know there are lots of expertise in the room and more expertise than I have at this diagnostic stuff, but diagnosis could be depression, schizophrenia, schizoaffective disorder, bipolar disorder. So that's the starting place. Evidence of a disability. So folks are unable to live independently well without lots of care and support, as evidenced by homelessness, right? Or lack of engagement in services, or cycling in and out of hospitals or even jails, unfortunately. And then duration, that the diagnosis and the disabling features are lasting for quite some time. So this will ground us along with the previous slide for the complex problems. And this is what we're talking about when we think about severe and persistent mental illness. Now we're going to go back to the 17 and 1800s for a moment. Now think about these disorders and the complex problems in what it must have been like back then. So let's start with talking about psychosis, right? And what is it? And again, if there are updates to these definitions or information you want to share, please shout out. But generally psychosis is defined being out of touch with reality, experiencing hallucinations and delusions, sometimes used more broadly to mean impairment that grossly interferes with the capacity to meet ordinary demands of life or activities of daily living. Now, back in the 1700s, for example, in America, what was required in terms of activities for daily living? Well, we were rural, we were agricultural, right? It required work and labor, right? Psychosis can be present, as we all know, in numerous psychiatric and medical conditions. Folks can get psychosis as a result of um, chronic physical health disorders or acute physical disorders, multiple sclerosis, other issues can result in experiencing psychosis. And psychosis and schizophrenia are not necessarily synonymous, although psychosis is certainly a feature of schizophrenia. So, um, any comments, reactions, questions, thoughts? Cassie, how was that one? Yeah,
Not doing bad for someone who's not a clinician. You're
yeah.
okay.
All right, fair enough. All right, then schizophrenia is probably generally considered one of the more disabling or the most disabling mental illnesses, onset between the ages 18 and 25. I've sort of heard if you make it to 40 without experiencing a severe and persistent mental illness, you're probably okay. And the range of this is probably 0.05 to 0.1% of the, or 1% of the population. So um, now, uh, ages 18 to 25, and again, I do a lot of work in the interface of mental health and criminal justice. If you think about those ages, 18 to 25, and some folks have extended emerging adults or young adults to 30. So if you take that 18 to 30-year-old group, it's where all the action happens, meaning if you're going to get involved in criminal activity, if you're going to develop a substance use disorder, if you're going to develop major mental illness, it's happening in that age group. So schizophrenia symptoms must be severe enough to cause impairment, person's ability to work or have interpersonal relationships or take care of themselves, and often characterized by hallucinations, delusions, disorganized speech, and disorganized behavior. I'm smiling now because take yourself back to the 1700s where we were rural, we were agricultural, we had villages and small populations, no medical care, no facilities, no treatment, no anything. So imagine what folks who are experiencing these symptoms, um, what it must have been like for them and must have been like for their communities. So symptoms having been present then um, for at least 6 months. And in my experience, at least talking with my psychiatry friends, they really try to do everything they can to rule out this diagnosis. I mean, they try to find other causes. This is really sort of the deep end of mental health diagnoses, and you don't get this after lots of ruling out of other things. All right, thoughts, comments. Claire, you look poised to say something profound. No, all right. I'm gonna keep picking on you. Um, okay, hallucinations. Now, again, 17, 1800s, think about this. Perceptual distortions perceived through any of the five senses, vision, hearing, taste, touch, and smell. Um, uh, really remarkable. Think about um, auditory hallucinations. And I would say, and I please challenge me on this, that we know as much today about the origin of auditory hallucinations, visual hallucinations, than we did 200 years ago, 300 years ago. I mean, we really have no idea. We have some medications that can manage these symptoms a little better, but identifying the area of the brain or how these disorders develop, we're still, not very further along from the 17, 1800s, I would guess, and hazard a statement there. Um, I also, the medications suppress but don't make all of these symptoms go away. And then I've heard stories again from psychiatry friends that when the voices are diminished or do um, manage better, people actually miss them. Because I did make the comment, and we'll get into magic and religion and supernatural as we're talking about some of the care and treatment. Um, voices do seem to be, dominated with religious themes and persecutory themes. And I was mentioning that to a psychiatrist friend. He said, well, not always, right? Sometimes they're friendly and supportive, and when they're managed and go away because of medications, people actually miss them. So it was something I'd never really thought about or resonated. All right, delusions are belief and impressions that are firmly maintained by an individual despite being contradicted what is generally accepted as reality or rational. They can be bizarre or quite normal. Like I feel like my neighbor is working for the FBI and is monitoring my, my daily routine here. Or I really feel like I'm a government official, working on a secret project um in Area 51, right? So it can be really bizarre, like I'm a famous religious figure, or it can be that's plausible. It sounds a little strange, but it actually could be possible. So um all right. So additional symptoms, and I'll interface here with the um, criminal justice system a bit, as we'll talk about later. But um, additional symptoms not required to make a diagnosis, but often present and contributing to the disabling effects. So, lack of emotional expression, poverty of speech or content, and then lack of motivation. So, a person with mental illness on probation, for example, has to do stuff, right? Has to meet requirements of probation, has to engage with a probation officer, has to answer, questions and converse. So I've heard many stories in working with probation officers who have individuals with mental illness on their caseloads that they perceive this flat affect, the poverty of speech, as a lack of motivation, right? Rather than a symptom of these disorders. So lack of motivation and probation requirements often don't go well together, at least according to the probation officers. So these symptoms strongly interfere with functioning and make medications rather make these symptoms worse on some occasions. All right, so we've got an overview of schizophrenia. There's other types of psychotic disorders, schizoaffective disorder, delusional disorder, psychotic disorder due, as I said, general medical conditions, or then substance-induced psychotic disorder. So these are the psychoses and schizophrenia, schizoaffective disorder. Again, put yourself back, hundreds of years, and these are the things people are walking around with. All right. Then we talk about depression. Generally, in the research that I do, depression, which runs along a continuum, it can be episodic, temporary. It could be dysthymia, or it could be severe, disabling depression, right? That is quite profoundly debilitating. So, depression, of course, can be very disabling, interfere greatly with ability to function. I typically don't include it in the research projects that I do. I stick to schizophrenia and bipolar, but nevertheless, it can often be seen as a severe and persistent mental illness. Um, and it's often people who suffer from recurrent disabling uh, depressions and who haven't responded well to treatment. So again, put yourself back into a rural agricultural setting, small communities, and people with these disorders. So this can come along with psychosis, um, but also it doesn't appear with psychosis and as well. All right. So then bipolar disorder used to be called manic depression, given the cycle between these poles. Everybody knows this. Imagine then these symptoms and America, colonial America in the 1700s, 1800s, right? Overly happy or ecstatic or extremely irritable with a bunch of these um, other symptoms. So extremely agitated, extremely talkative, rapid speech. Um, must be severe enough that it causes problems in social or work performance. Person is hospitalized. Person can also have psychosis with this. So these are really the three when we talk about diagnosis, duration, disability. The primary diagnoses we're talking about when uh, we refer to severe and persistent mental illness. All right. Questions, thoughts, comments? Everybody still awake? All right, good. Okay, so let us progress. Oh, no, went the wrong way. Okay, here we go. So that's the context we're in. And colonial America, in the 17 and 1800s, individuals with mental illnesses, really didn't receive any attention. These people were labeled as mad or distracted. Everybody lived in rural agricultural settings, and really care, treatment, well, no care, there was no treatment, was really an individual or a family matter. Families were left on their own to take care of individuals living with these disorders, which seemed bizarre. People tried to come up with explanations for them, as you'll see in a little bit, but we had no concept, right? We have barely a concept now, pun intended. Our concept of social policy for care and treatment of people with mental illness is deteriorating rapidly, I fear. So no concept of social policy back then. Um, and it was truly an individualistic family matter. Um, a lot of it, was based, the emphasis for managing these folks was based on social and economic issues and consequences. So, there was this English principle that carried over and that ultimately took root, that society does have a corporate responsibility for the care and treatment of folks. We did see early in the mid 1600s, the first local legislation which mandated care by community, which back then actually in sort of a progressive way, uh, individuals, family members were required to care for individuals, but supported by the community. So uh, there, however, was no, the focus and the worry about mental illness was the threat to public safety and the labor loss. Again, agriculture, rural place where people are dependent on labor and work um, to survive. So there was no emphasis on treatment. There's few boundaries between magical thinking, religious thinking, science, and medicine. So care really was clergy and the um, uh, cutting edge treatment was bloodletting, purging, uh, exorcisms, and trephining. Who knows what trephining is? I'm not gonna continue until someone answers this question, and not you, Cassie. Trephining. Anybody? This is going to be a little graphic, so trigger warning. All right, well, trephining is actually drilling holes in the skull to release fluids. So we haven't done this in a while, thankfully, but that was one of the treatments. I mean, if you can imagine back then, exorcisms, bloodletting, purging, and trephining were the treatments of the day. So fortunately, we've come a little bit further along. Okay. All right. Moving on a little bit, we then moved from um, uh, uh, the thinking that it was spiritual, it was um, uh, religious or magical, to more natural interpretations of, again, what's still being called madness. So restoration of equilibrium. So basically your bodily fluids are out of whack. You've got too much bile, too little bile, and the prescriptions for that were, restoring equilibrium. So it literally could be through a balanced diet, exercise, avoiding liquor, tea, and coffee, right? Those were the treatments to restore equilibrium, which is, the interpretation of being mad was you were out of balance. Um, for the most part, unless there was a threat to public safety, people were left to their own accord. They could work if they were able, but bizarre behaviors were mostly tolerated. Um, uh, um, Confinement, meaning, people were locked in their houses or locked in rooms in their houses, um, by family members if behavior was a threat to public safety. So again, we still have, family-driven, individual-driven care with some support from the community. But again, no treatment, right? Um, really. Now, as populations in cities grew dense, this became more of a problem, right? Threats to public safety um, uh, became issues, and actually, the first emergency mental health hospitals started to happen there. First in Philadelphia, and then actually the first public mental health hospital. I did not know this was in Williamsburg, Virginia. Cassie, did you know that?
I did know that
Yeah,
since I have to live here.
yeah.
Yeah.
So this was the late 1700s, and the provision, the legislative provision, was to support, um, uh, idiots, lunatics, and the misspelling of idiots is just how it was spelled. So I didn't have a typo there, but idiots, lunatics, and other persons of unsound mind. So hospitals, right? So now we need to staff hospitals with people with expertise, hopefully, or at least staff them to keep them safe. So a lot of this comes from, I'll reference at the bottom, Grove's Mad Among Us, which is a great book. It's a great read. So I want to give attribution to a lot of what's in here. So if you don't have a copy and you happen to be in the School of Social Work here, come by my office. I'll loan you my copy. Um, okay, so now we've got family and community, um, care, some primitive sort of explanations for mental illness. Now we're starting to see, as population in the America grew, we're starting to see public hospitals in our large urban settings. Um, so this continued, and really we had the birth of asylums, right? Boston, Philadelphia, Hartford, New York were really the start of this, and it's interesting because mental health hospitals really started out as resorts that catered to the affluent, and they were seen as places to go for rest and recovery and recuperation. So what these hospitals try to do, private hospitals, is attract affluent people who could pay lots of money for long stays, right? This, of course, wasn't sustainable and didn't meet by any stretch the growing, public health, public safety issues of more and more people with mental disorders being in these large urban areas. So these affluent private hospitals, mental hospitals, had narrow admission criteria. You had to be wealthy to be able to get in. Um, and they were supported mostly by philanthropists and not community, not local government or state government. And then really, as I said, had ultimately no hope. So the emergence of large public hospitals happened, um, but really served, given the growing uh, public health issues of mental illness, homelessness, violence. Um, uh, Large public mental health hospitals were starting to emerge, but served mostly a custodial function, so a place to warehouse people who were seen dangerous to public safety. So no care and treatment, really, just custodial in function. And then in the mid 1800s, Dorothea L. Dix, there's a Dorothea L. Dix in hospital in Raleigh, North Carolina, where I used to live, really started the emergence of large scale public health institutions, started getting states to think about mental health policy, funding state hospitals, and the care. Then what Dorothea advocated for was, let's get, this is novel, but let's get psychiatry, which was emerging then, into the hospitals rather than custodians of care. So the mentality of what we were going to do in these large hospitals now changed to treatment rather than custodial care. Now, treatment was still not very far along, very sophisticated. So again, trigger warning, we're going to talk a little bit about the type of care and treatment that individuals with mental illness received. and then we'll move into more of a picture of, what's happening today. But before I go much further, any questions, comments, thoughts? All right, so we've got all these growing number of folks with these symptoms we can't explain or treat. Then we've got larger and larger urban areas, and now it's becoming a public health issue and a safety issue, and people do need uh, uh, a place to go. We have the emergence of the large hospitals, and then Dorothea Dix is coming along and advocating for policy, more sophisticated treatments, and then financial support. All right. So treatment, with the smaller facilities, as you think back, there was an opportunity to try to be more treatment focused. Smaller facilities, fewer folks in them, and what I said earlier about restoring equilibrium, a lot of the treatment in these smaller facilities was hard work, um, balanced, exercise and fresh air and things like that, which you could do if you weren't having to manage larger groups, is larger facilities and more complex populations. So if you think about these larger hospitals, um, with lots of different symptoms, um, uh, different, even socioeconomic levels, they became much more complex. And really, it wasn't about treatment as these hospitals got larger, it was about management and administration. So then the treatment really came about, focused on control. Now, this is no different, right? We'll make a connection to the criminal justice system and prisons and jails, which are all about control, right? And how to manage population safely in these facilities. So as these facilities got larger, populations got more complex to serve, as staff were poorly trained, poorly paid, um, then care was completely, or treatment was completely about control. So prior to the 1950s and the advent of medicine, more sophisticated psychiatric treatments, as you might guess, it's about restraints and straitjackets, padded rooms. Who knows, other than Cassie and anyone who took Cassie's class, bath of surprise. Who ever heard of a bath of surprise? Okay, Sid, you
Sorry,
want to tell?
I cheated a little bit and Googled it a minute ago. It's just like drenching the patient in like freezing water to like induce some sort of reaction.
Yeah. So the idea with these treatments here is to make someone so physically uncomfortable that they forget about their psychiatric symptoms. Yeah, it is sad. That was the thinking of the day. Now, bath of surprise, the way I've seen it and read it described, is they will blindfold someone, in a corner of a room, and then begin to walk them across to the other side of the room. But halfway through, they deposit this person into a freezing bath of water. The idea is to make them so uncomfortable that it jolts them out of um, their symptoms. Unfortunately, a lot of physical abuse and violence, beatings, just to get folks to quiet down, to comply. This characterized our institutions in the 50s. Now you can see where we're leading with deinstitutionalization. Once this, was discovered and folks realized what was going on, and then I think it took actually the institutionalization of one of I think it was John F. Kennedy, president's niece, or I don't know if it was a daughter. Does anybody recall what the relation was? But someone with an intellectual developmental disability, right, who was in one of these facilities, and it was so squalid and horrible that this really catalyzed initiatives and efforts to make some changes. Um, so we've got the bath of surprise. If anyone ever offers you that, feel free to turn it down. But again, these are overcrowded, dangerous, squalid places maintained by poorly trained, poorly paid staff. It was a dangerous job, low pay, and so forth. Now, I don't think this would be called a progression, but there was sort of a new wave of treatment in the 50s, ECT, electroconvulsive therapy. And how many of you, raise your hand, have seen One Flew Over the Cuckoo's Nest, the movie? This is a must watch if you haven't seen it. It was back in the 70s, shot at a state hospital, I think in 2 different settings, maybe Washington State and Oregon. But this is a Jack Nicholson movie, and really it's written or adapted from a book, One Flew Over the Cuckoo's Nest by Ken Kesey, Kesey. It's a terrific read. The movie is in the uh, perspective of one of the patients, Jack Nicholson, but the book is written from the perspective of a Native American that is actually hospitalized with the lead character. So it's very interesting, very good read, very good commentary on what treatment was like, how we thought about mental illness, and how we controlled people who were hard to manage in the community. So we got ECT, which is still around today. It is used for treatment-resistant depression. But then medications took hold, and you can think of those as medical straitjackets, right? People did insulin coma therapy, putting folks into a insulin initiated coma to quiet symptoms. Thorazine and other medications, metrazole induced a seizure, right, to get symptoms under control. Probably the worst and most graphic, trigger warning, was frontal lobotomy. And there are stories written about psychiatrists who would go around to towns all across the Northeast performing frontal lobotomies. And again, trigger warning. Really, the method was to take ice picks and drive them through the eye sockets into the frontal lobe and basically scramble. That was the frontal lobotomy. And there was one historic account of a psychiatrist who drove around in a station wagon, doing 50 or 60 of these a day, and his arms would be so exhausted by the end of it. So these treatments, as you might imagine, are the frontal lobotomies were not effective at all. I mean, it did tremendous damage, inhumane, unethical, poorly trained. This was the medical knowledge of the day, though. So this is where, we really were at leading up to focus on psychiatric medication. So, I would say today our treatment is more humane, certainly, than it was, right? And more effective with managing symptoms, but not great. And again, as I said, we still have no clear understanding of the origin of auditory or visual hallucinations, or just how to cure, I guess, right? We have no understanding of that. So we're going to transition into more of today, but I wanted to invite reflection, thoughts, comments before moving forward. And I'm going to take a sip of water.
Hello.
Hello.
Hi. So I actually worked with I worked in a PACU where we did pre-op and post-op for patients and outpatients getting ECTs.
Yeah.
They don't still think that's archaic. I know they're coming out with that TMS, but there's not much research as far as if it's as effective than ECTs. The patients actually, some of them actually say it does
Yeah.
help them. So I mean, it always felt that it was archaic. I was a little bit like, this is
Right. And I would hope, and
Mhm.
please chime in with additional expertise, the
Mhm.
depiction of it in One Flew Over the Cuckoo's Nest, the movie and the book, is about,
Mhm.
managing unmanageable, or at least people who are labeled unmanageable, with so
Mhm.
much electric shock that they become vegetative, right?
Mhm.
Now, that's not what we do today,
No,
right?
it's not
But
what I've seen. Yeah.
yeah, that was the point of it back then.
Mhm.
Now we're much more sophisticated.
Mhm.
So it's good that it's used
Mhm.
effectively.
Okay.
Yeah. Other thoughts or comments?
Mhm.
Clara and then Sydney.
I'm thinking, just as I'm looking at your slide, Gary, that even today, some of the management techniques that you put into your management, including prior to 1950s, hasn't actually changed that much.
Yeah.
Still use restraints,
Mm-hmm.
straight jackets. We just use handcuffs.
Yeah.
Physical beatings happen. Units are sometimes violent and are maintained by staff who unfortunately aren't trained well enough to deal with people with serious mental illness.
Yep. That's absolutely right. Sydney?
Yeah, I was actually thinking the same thing, Clara, of just like there's still a lot of overlap in a very horrifying way. My question was, so you mentioned that like around Dorothea Dix, there was not really, that's like kind of when psychiatry emerged. Would that apply to like psychology, mental health as a whole was not really existing until that time?
Yeah, and I would say it came later. I mean, you know, the I would say, and please folks chime in too, that because psychiatry is a part of medicine, medical doctors, that's what the aspirations were. Um, and that's how, you know, the field developed out of medical practice. So I would say, um, you know, clinical psychology, you know, mental health counseling, some of the other disciplines probably came, you know, a decade or later after. You know, psychiatry, and I've got lots of good friends who are psychiatrists, and they'll say they are on the bottom rung of the medical profession. They are, you know, the least paid, the least respected, you know, medical practitioners. So I think that uh, um, it unfortunately is the case. So yeah, it'd be interesting to learn more about the history of psychology and other disciplines that are now focused on folks with mental illness. Good, but no psychology was going on back then. It was either psychiatry or, you know, again, custodians, and you know, correctional officer as a characterization of what these um, folks were is probably not far off the mark. All right.
Can I say
So
one
that,
thing really fast, Gary?
oh, of course, yeah.
I just kind of wanted to go with what Clara was saying. Before working in an inpatient facility, I was very naive in thinking that restraints did not happen as often as they do. And it's the same with like what you have here is pet in the concept of padded rooms. So even
Right.
outside of inpatient facilities, like I've worked in school settings with students with like 504 plans and IEPs, and the versions of padded rooms can exist in schools. So it's really interesting when you step back and you think about what you have listed with management care and how versions of this exist in all different environments,
Yeah.
and how if you're going to do clinical work, which is like what I do, what this looks like now, and then what our roles need to be moving forward. So, you know, just how I've seen, like Clara mentioned, people that don't have maybe as much training or the training we want them to have, and how they engage in restraints versus how the very minimal times that like I've felt myself having to do a restraint, how I would do them. So just food for thought about for how you do those things moving forward, all of you
Indeed.
in our program.
Thank you, Cassie. So keep all this context, right? Um, custodial care, lots of these things that, uh, you know, unfortunately are still used today. And let's transition into, and I'm going to come back to one of the slides we showed in a minute. All right. So because of the squalid, terrible, horrible conditions, um, the fact that these hospitals were not curing or treating or making anybody better, a lot of convergence of things. Um, we started deinstitutionalizing our large state hospitals, you know, back in the 60s. And the idea back at the time was that we would save so much money um, uh, closing these hospitals down that we would move funding for care and treatment into the community and get the community to do it. Of course, that never happened. Money did not follow. Right now, um, There's probably 37,000 folks in our network of state hospitals across the country, but there's probably um, 750,000 in our prison system. Um, uh, is that high? No, I think close to 300,000 are prisons. On any given day, um, there's probably 100,000 in our network of jails, 3,400 jails across the country. And there's probably 1.5 million individuals with SMI and probation and parole arrangements. So you might think of this more as trans-institutionalization, meaning they transferred from one institutional setting to another. So from the mental health system, state hospitals, to the criminal justice system. And if you think about as bad as they were, the state hospitals, care and treatment were together, right? People had a place to sleep, they had recreation, they had food, treatment, was there. After deinstitutionalization, people were diffused into their communities to try to now navigate these separate systems. So go one place for care, another place for treatment, trying to navigate Byzantine bureaucracies to get housing, benefit programs, food stamps, physical health care from one setting, substance abuse treatment from another setting, it's supported employment from yet another setting. So all of this now has been diffused, and those systems are hard enough for us to navigate, right? Let alone someone with a disabling, uh, severe and persistent mental illness. So public mental health system shrunk. We diffused and put all the folks now out in the community. There are still some state hospitals, and there is some national dialogue now and then about, gosh, let's bring back, they don't call them asylums, but let's do the state mental health hospital system, make it better. But what we're doing now is not working, as evidenced by, and we'll talk about that in a moment. So criminal justice system, unfortunately, is now the place where the majority of our folks with mental illness, they are. And whether it's juvenile facilities, I'm doing some work, which I'll talk about at the end, with Bon Air Correctional Facility here in Richmond. That is the last state juvenile correctional facility. 90, and it's a census of like 150, maybe 125 kids. 95% of those kids are on psychiatric meds of some sort. So talk about place of last resort care and custodian of people with mental illness. It's the justice system. So this has implications, right, for social work practice, policy, research. And there's social workers in Bon Air, there's social workers in Chesterfield County Jail, where I do some other work. So that's good. If you think about it too, the fates of people with severe mental illness are closely intertwined with criminal justice policies, not only mental health policies, but other policies. If you change a city ordinance about public urination or panhandling or soliciting or public disturbance, this will impact those who are most vulnerable and marginalized first and foremost, right? People who are homeless, people who have severe mental illness whose symptoms are not treated. And then, as we see over and over again, criminal justice system is really the place of last resort. So we shifted from these mental health institutions, large public hospitals, into really the criminal justice system. And the notion of a public health outpost is sometimes, unfortunately, and again, it's a testimony to where we're at as a community when it comes to ethical treatment, moral treatment of folks with mental illness. The justice system is often someone's first and best chance to get diagnosed with a mental illness or with even a chronic physical health condition, because of a constitutional mandate that these institutions have to screen and have to treat, right? So trust me, jails and prisons don't want to screen folks for, cancer, physical health, or even mental health. But once detected, then they have to do something about it, right? They have to provide care and treatment as they're constitutionally mandated. All right, so we've shifted now. Now imagine we've shifted treatment, right? So what kind of treatment are folks receiving in prison and jail facilities? We're going back to control and people who are custodians rather than care and treatment. Okay, any questions about that? Yes.
Yeah, could you repeat again why the public mental health system shrunk? Like it wasn't working, it was too expensive, both?
Both, and the conditions were squalid. They were unsafe places. People weren't getting better. Hard to manage. States didn't want to continue to pay. They tried to push it out on the federal government. So just no pun intended, but the care of the hospitals, was a debate. So sort of convergence of policy, public health issues, as well as the fact that these hospitals were really not helping, and mostly inhumane, squalid conditions. The thinking was, if we can move folks out in the community, reconnect them with family, reconnect them with, their places of origin, and then wrap treatment around them. And that was the part that failed. There was no treatment dollars that necessarily followed folks into the community. All right. So back to this slide, right? We're right back where we started. Now this is a problem more than ever, right? We see lots of folks with severe and persistent mental illness, with lots of social isolation, socialized, internalized stigma, lots of unemployment, lots of substance use, lots of chronic physical health problems that they don't get treatment for, and then lots of homelessness, right? So we're sort of right back where we started, with these complex needs with little solution for them. And then in the red here, we have evidence-based practices, for all these things for folks with severe mental illness. We've got supported employment interventions. I'll talk about that a little bit later. We've got interventions that can be added to treat substance use, added to assertive community treatment teams. We've got coordinated care models to blend physical health care and behavioral health care, reverse co-located, services, so putting primary care in mental health settings. We've got coordinated specialty care for folks who have first episode of psychosis. We've got housing first interventions to try to get folks housed. So we're working on all these issues. If you think about a lot of these issues, they're driven by, poor outcomes are really driven by social determinants of health. And if I'll talk about this, later. If we took care of housing needs, took care of employment and income needs, took care of social support, how much better would outcomes be for this population? So right back where we started. Then this is pointing back to some of my own research. So what I'm focused on in my research is interventions for folks with severe mental illness, particularly those who are involved in the criminal justice system. So these data come from a sample of folks on probation in North Carolina who had severe and persistent mental illness. And basically what I wanted to show is the impact of high or low social support on a number of things. So the red bar is folks, in the sample with low social support, and the green bar are folks with higher social support. And as you could see, folks with lower social support are less likely to have mental health services. And this isn't causation, but it's correlation. They're more likely to have a diagnosis of PTSD. We'll talk about trauma in a minute. More likely to be functioning in terms of their mental health more poorly. So again, it's correlation, but if social isolation and stigma is a problem, and then here is some evidence that yes, it is, interventions designed to get folks into community, to provide peer support, social support are really important, right? So the slide I showed with the different pictures of all the different problems, I'm going to show you research that I've done to lead to the development of interventions to address those problems. Okay, so any questions about social support? All right, and then trauma, good gracious. I think one of the, particularly think about the interface of mental health and criminal justice. Um, I think trauma is going to be the next big challenge. And so many of these individuals with severe and persistent mental illness have undiagnosed, untreated trauma, have experienced a lot of traumatic experiences. And then let's back up to those hospitals in the 1950s, where all the treatments that we looked at, a lot of beatings, a lot of physical trauma to try to get folks to forget about their psychiatric symptoms. Being hospitalized for many is a traumatic experience. Being arrested is traumatic. Just having um, these repeated events. So these are data where I asked folks with severe and persistent mental illness to identify traumatic events they experienced in their lifetime. So there's like 18 different categories, and here's just 4 of them. But this is a sample of 200 folks. 80% of the sample of individuals on probation with severe mental illness experienced physical assault that was traumatizing to them. Over 60% an assault with a weapon, 50% a sexual assault, 40% almost a life-threatening illness or injury, and 90% of the sample, almost all of them, experienced some interpersonal trauma. All right. Now, what you didn't see on the slides that I talked about with the early emergence of the asylums and the state hospitals and anything related to trauma, right? It wasn't, they were trauma-inducing facilities, and we were not attending to we didn't even have words for this back then, right? Post-traumatic stress disorder and trauma. Now, half of these individuals met diagnostic criteria for post-traumatic stress disorder. Put that in the context where a lot of them are in criminal justice environments where there's no recognition of undiagnosed, untreated trauma. And those environments themselves, like administrative segregation, social isolation, are re-traumatizing. So this is a bad combination of the setting that they're in, plus this undiagnosed, untreated trauma. So if you're working with this population, particularly if there's justice involvement, it's likely that there's undiagnosed, untreated trauma. How does this manifest with engagement with law enforcement, probation officers? Well, not attending to it means maybe misinterpreting inability to establish rapport, reluctance to engage, fear in, being out in public, fear of riding public transportation, a lot of ways that, again, may be misinterpreted as non-compliance, right? Okay, any thoughts or comments about this slide? All right. I'm going to speed through because I think I'm running out of time. All right, physical health problems. These are data from a study I did. And really what this shows is folks with SMI or the green bar, folks with justice-involved SMI or the red bar. And, we've moved from one institutional setting to the other. But care and treatment and sophisticated psychiatry and medicine didn't move over, right? But here are all these problems. So folks who are justice involved with SMI are much more likely to have infectious diseases, blood disorders, skin disorders, have injuries. Now, from a public health perspective, you don't want folks being released from justice settings with untreated infectious diseases, blood diseases, right, skin disorders. But there's literally no communication between these public sectors, right? Public health, or rather local jails are not communicating with the local public health office saying, hey, Gary's getting ready to be released. He had 3 months of his 6-month trial for tuberculosis. So you got to find him right away. You got to continue him on his medication, or he's going to be out there possibly infectious with this disorder. So, all right. So lots of physical health problems. Any comments or questions on this one? All right. So I'm again painting this complex needs population with evidence to support it. I also asked the same population of individual on probation from the mental illness about their basic needs and some other things. So as you can see in those red bars, those are folks who have these needs. The green bar are folks who had actually received services. So the way to interpret the basic needs, for example, is 65% had, food, clothing, and shelter needs, and then only 60% of the 65% actually received any services related to that. So it's a needy population: medical care, dental care. Um, these are not a population that's getting routine dental cleanings every 6 months, right? So a lot of unmet service needs as well. Transportation and housing are certainly issues that add to the complexity of the needs of this population. All right. So lastly, the justice system, and again, juxtaposing the institutional settings where, psychiatry was emerging and folks were trying to treat mental illness. It's not what the criminal justice system is doing at all. These are some criminogenic needs. This is what probation officers and other service providers in the justice system are trying to address, because these are the factors related to justice involvement. So these are called criminogenic risks. Mental health is not a criminogenic risk. Um, but individuals with mental illness have higher elevated levels of these criminogenic risks. So this is a sample of probationers, people on probation in North Carolina. Green bar, no mental illness. Red bar, mental illness. You can see people on probation with mental illness more likely to have substance use, antisocial personality trait, have a self-reported dysfunctional family history, impulsive, lack self-control, and have antisocial values. So you put this complex need population in a care setting. We're right back, where we started. You put them in a custodial care setting with poorly trained, relative to the mental health needs, poorly paid staff who now have become the custodians of mental health care, substance use, physical health care, and throw in the undiagnosed, untreated trauma that I mentioned. So this is where we were at. What is it about, really? And I referenced this early. These folks have needs related to the social determinants of health, like all of us, right? So if we did, as a policy, and got it together and did safe and adequate housing, if we did supported employment and meaningful daily activities, provided interventions that got folks more connected to social support, in addition to mental health treatment, I think a lot of the issues that we see around homelessness, unemployment, low education, a lot of the stuff that often leads folks into the justice system would be addressed, right? But we don't have near enough resources, funding, housing, jobs, supported employment arrangements to address this. So having more social policy and more focus on these just basic things, right? And I often say, what we need to do first for this population is get them a bed, a buddy, and a job, right? Let's get social support. Let's get safe and adequate housing. Let's have meaningful daily activity, supported employment. People want to live meaningful lives, just like we do. A lot of these individuals want to work and walk in neighborhoods that are safe and have community. So, when deinstitutionalization was occurring, we weren't thinking about these policy issues either. How are we gonna? These again are Byzantine bureaucracies that are isolated, that don't, work well with each other. So unfortunately, little has changed through the years. Some work that I've been doing in state settings. This was in North Carolina, providing because there's so many people with mental illness on probation, providing mental health training. So there are a bunch of modules I created, and it's policy. Speaking of policy, now in North Carolina, and I'm trying to work here now in Virginia, that all probation officers now have to go through mental health training. So it's a little more, not quite crisis intervention training for police officers, but also more advanced than mental health first aid training. So that's good. It's sort of a illustration of where research meets policy to try to improve things for thousands of people with mental illness on probation. One finding in examining the effectiveness of the training, mental health knowledge among probation officers increased, which is good. And then perceived stigma decreased, which is good because there's evidence the less stigma you feel towards somebody, the more likely you are to engage with them. So that was a good outcome for this training. I've been running around doing mental health probation and trying to add different evidence-based practices to mental health probation. So I finished a study where I added a supported employment intervention to a mental health probation unit because one of the primary requirements of probation. Now think about this with all the needs, the undiagnosed, untreated trauma, the symptoms, social isolation. Primary requirement of probation is often go out and get a job, right? So someone with a full-on mental illness with all these complex issues, it's not easy to even meet that probation requirement. So the thinking behind this research was, well, let's add an easier way for folks to meet this supervision requirement that is actually an evidence-based practice adapted for folks with mental illness. And then lastly, this is my last slide. This is a project I've got going on now, and this is with Bonaire Juvenile Correctional Facility. It's where sort of the deep end kids, unfortunately, end up. It's the last state-controlled juvenile correctional facility. Most of the kids in there have behavioral health disorders. We wouldn't see full-on severe and persistent mental illness, but certainly precursors of it. All this, the research that I presented in terms of the stigma, the social isolation, the homelessness, the lack of employment and unemployment rates, and as well as the trauma, I've combined elements into one intervention. So we've got a trauma-informed care specialist who provides brief counseling. We've got a supported employment team that are hooking these youth up with jobs, and then we've got credible messenger peer support workers. So we're trying to address a lot of the issues that I talked about throughout all at once, bundling these services together to try to improve reentry outcomes for folks who come in institutional settings. And I think that is it. Yeah, thanks. I'm going to stop sharing.
Does anyone have any questions for Gary as he wraps up his presentation? Or comments or anything really?
Gary, I loved the bed, the buddy, and the job. I love that. I would modify it a little bit. I work with kids,
Yeah.
so kids who I suppose could get a job, but really need to do something a little bit different with that. But
Yeah,
so much of what we do, we overlook those things.
right.
And we focus so much on diagnostics or focus so much on medication, or did I do CBT or did I do DBT, that we miss some of that other stuff that if we solidified that might actually make the mental health better. I'm not saying it's unicorns and roses, but it would make it better.
Yeah. Thank you, Tara. So maybe bed, buddy, and a hobby.
Something.
Yeah. For the youth. And somebody added too, especially this will resonate with those of you working in rural areas, that there's no transportation, right?
Yeah.
To get anywhere. So I was doing a presentation like this and someone said, you ought to add transportation. So you could say a bed, a buddy, a job, and a buggy, right? Right. Sydney, did you have a comment?
Yeah, sorry, I feel like I have so many questions. Project Belong, I think
Yeah.
you mentioned, when did that start?
We're getting it cranked up now. So we're going to start serving kids within the next month.
That
Yeah.
project sounded so cool. I was just curious to see how it had been going so far.
Yeah. I'll let you know. So we, working in juvenile justice settings, it is a study. So we're going to examine the impact. So the justice system, doesn't like the R word, research or study. So It's taken a little while to sort of get into Bon Air. We expanded to Richmond Juvenile Detention Center. We'll also work with kids who are released from either of those settings in the community. So come back in 6 months and
Okay. I'll circle back.
give you an update. Yeah.
Thank you, everyone. I just want to say, make sure that you filled out the attendance form if you haven't. I put it in here a bunch of times. We are so sorry for the confusion at the beginning. I know we apologized a bunch, but thank you for that. Gary will stick around with me for a couple of minutes. If you have any questions you want to ask him directly. Our next conversation for this SMI series, where we will definitely make sure the correct links are sent out, is on the 13th at 6. It is, I was very excited for this one. I'm really, really excited for the next one as well. It is going to be focused on maternal mental health, in particular, African American women. The speaker is someone who's currently getting her Ph.D. at the VCU School of Nursing. She's amazing. Her name is Ariel. Hill Thomas is her last name. I actually had to I couldn't remember her last name because I've just called her Ariel forever, so that's why I was pausing to look up her last name. She is amazing. Ariel is a doula. She is a nurse. Like I said, she's wrapping up. She actually goes to defend her PhD in 3 weeks. So her entire career has been focused on pregnancy and motherhood in the African American community. So that's what she's going to be speaking about, in particular, work with women who are diagnosed with bipolar disorder and that are pregnant. So if you have any interest in that, that would be the next talk that we will have. So as someone who has been a long-term clinician, I think it can be really challenging to find, sorry, this is my dog, find experts who have worked directly in that population.
I'll echo
So
the sentiments. Yeah, thank you so much for coming. Please reach out if you have any questions or just want to talk, or if you have any interest. So we've got the clinical lecture series. We're doing clinical supervision. We've got a mental health certificate courses that we're putting together. As one of my initiatives here is just to do more mental health. So really, Cassie's been the architect of a lot. Tara helps out, Clara helps out putting together our courses. So we're really excited about what we're offering. If you want to talk to me about being a field instructor and you're interested in doing that with us, or if you want to teach, please don't hesitate to reach out. We're always looking for excellent folks, particularly in the mental health space. So please don't hesitate to contact me.
and if you don't want to talk to us, you're good. So thank you so much and have a good night. And thanks for being here.